In some places, they were judging physicians whether they were practicing good medicine by whether they were using McKenna, which the absurdity of this now that we know that it didn't work, but at the time it was a way of almost forcing physicians to be giving this to their patients so that they would be getting credited with good care. It's almost like a mandate of sorts, pushing people to forced use of the drug.
Somebody get this guy some help!
Or, put more simply,
If you need help like this guy, call your own doctor.
So, little detour, but we'll come back around. That's how my mind works usually. And most of the time I come back around. Adam, are you a basketball fan?
I'm a big basketball fan, absolutely.
So if you've been following the NCAA men's basketball selection process, there's been some major public backlash due to a gross conflict of interest, mind you, with much less serious and significant consequences than people's health. But long story short, the University of North Carolina's athletic director, Bubba Cunningham, the chairman of the March Madness Selection Committee that chooses the teams that get to compete in the 68-team NCAA basketball tournament. Now, nearly every reputable bracketologist or analyst who follows college basketball religiously updates their rankings weekly, if not daily, throughout the regular season, uses several different metrics to determine whether or not a team deserves what's called an at-large bid or a selection committee bid into the tournament. All of the bracketologists said the University of North Carolina, the Tar Heels, did not belong in the tournament, and it really wasn't that close. But UNC got into the tournament anyway. People are all up in arms because Bubba Cunningham, the chairman of the committee that gets to decide who gets into the tournament, got a nearly $70,000 bonus for UNC getting into the tournament. He's due to receive additional bonuses depending on how far they advance. So his response to the public backlash of this being a clear and gross conflict of interest was that he wasn't in the room while the committee, comprised of 9 other, I think, all athletic directors, was discussing North Carolina, which is a ridiculous defense because leaving the room doesn't dissolve away pre-existing relationships that Cunningham has with other committee members, which I'm sure is a good old boys club. Cunningham is in the room when discussing other teams that are directly competing with UNC for one of those final at-large spots. Not to mention, how do athletic directors of major college sports programs have time to follow the entirety of the college basketball season, some 350 teams, with all their other roles within the university? So why am I bringing this up on Renegade Psych? Well, you've talked to me before. You know that I have an innate burning skepticism of our healthcare system, the FDA approval process, what is promoted as dogmatic clinical guidelines. And this looks awfully similar to what happens in medicine. Guidelines are published in major medical journals or promoted by major medical organizations like the AMA, the APA, or the ACOG, the American College of Obstetrics and Gynecology, advising doctors and providers who read their materials on what they should consider first-line treatments for any given condition. Fundamentally, how is what Bubba Cunningham did any different than what happens every freaking day in medicine? If I'm the APA and I receive a huge amount of funding from makers of serotonin reuptake inhibitor antidepressants, you know I think they're anti-anxiety drugs, throughout the 1990s, 2000s, and 2010s, is there not an unspoken agreement that I'm going to promote SSRIs as the treatment of choice or otherwise lose my funding? And this is not just a theoretical concern. I mean, I bring it up to you for a reason. It was very real with McKenna, as you and so many other OBs were advised to use it as a first-line treatment. And I can't remember if it was you or my other OB that I had on, Ann Greider, who said that they were threatened because you were not using enough of it in the eyes of administrators. So
Yeah.
can you respond to this absurdly long question, Stem, and expound upon this problem of enmeshment of pharmaceutical industry and interest within major academic institutions, medical journals, and publications, and the medical organizations like APA and ACOG?
That's the huge problem. And that gets back to what I was talking about with that the protective layer, the information systems have really broken down. And that conflict of interest, as you said, is pervasive. I liked your question, by the way. I think it's great to tie it in. I used to tie it in with baseball and say that, nobody would be happy watching a Red Sox Yankees game if you knew all of the umpires were being paid for by the Yankees, and if after they finished umpiring, they were going to join the Yankees organization. It creates an actual conflict of interest. It actually creates influence. But even if you want to make these strange arguments that no, the humans are immune to this and they're actually not being influenced, no one can argue that it doesn't create the perception of conflict of interest and then cause people to lose faith in the process. It's a huge challenge, though, because all of those layers, as I was mentioning before, are essentially being bought off. They're being flooded with corporate cash. And so you see this in the case of McKenna. McKenna was a preterm birth drug that we used going back to 2003. We gave it to pregnant women literally for 20 years, from 2003 to 2023, and it didn't work. The first trial where it got its FDA provisional approval was
the typical length of a patent exclusivity for a company? 20 years from the time that it is developed. Yeah, I
is it
believe
20?
it's 20.
Yeah.
At least with the psychiatric drugs, my understanding is it's 20, and then if they get other indications on top of it, they can squeeze a few more years out of it. And I bring that up because you said it was 20 years between the time it was approved and then when it was taken down, or the FDA then banned it. So that always just is interesting to me that they're willing to ban it 20 years later.
Yeah, no, it's remarkable. Actually, the story's even worse because the initial trial was 2003. The confirmatory trial in 2019 showed that it didn't work. And I really thought at that point it should be pulled. So I started making even more noise at that point because now we knew that it actually didn't work. But it stayed on the market for another 4 years. And again, I think a lot of people had the thought that they're doing that so they can churn as much profit out of this as possible. And I've had women contact me who actually were started on it after the 2019 trial came out. They're very upset that they didn't know about this. They were started on the drug in 2021, after we knew it didn't work and that it continued to be on the market. And the problem was that these expert panels or these professional medical associations that put out these guidelines are very powerful. And they're often being paid by pharma, and they often put out guidelines that are friendly to pharma. In our field, it was considered standard of care to recommend using McKenna to prevent preterm birth. And this was by organizations who were receiving money from the makers of McKenna. And it's clear when the public realizes, but I think the public doesn't or didn't quite understand the extent of this. One thing I think that it's helping is the opioid crisis, because I think that really, with that and all of the television coverage, people really understood a lot more how this sort of system of corruption essentially works to lead to these recommendations. And then the last thing that really bothers me, you touched on for a sec, which is that in some places they were judging physicians whether they were practicing good medicine by whether they were using McKenna, which the absurdity of this now that we know that it didn't work, but at the time it was a way of almost forcing physicians to be giving this to their patients so that they would be getting credited with good care. It's almost like a mandate of sorts, pushing people to forced use of the drug. So all of these mechanisms are in place, and I think the public didn't or doesn't, still much of it, understand the extent of these financial relationships that determine how medications get used, how they get recommended, et cetera.
Yeah, I think you and I touched on the fact that when you say some of these things, especially publicly, sometimes people want you to put on your tinfoil hat and declare yourself as a conspiracy theorist. But there are so many examples of this happening, and then us chasing our tail for 20 years and then saying, oh, yeah, that Makena wasn't a good drug. We were manipulated. That Vioxx, it really wasn't a good drug. It wasn't anything better than what we already had. We were manipulated. Oh, Purdue Pharma and Oxycontin. Oh, wow, an opiate is addictive. Wow, who would have thought? I mean, that if that's not the most common sense,
Yeah.
statement that we believe the opposite for too many years. And again, I don't think that everybody believes what these companies are putting out. But the reality is, if you have somebody at the top of the information totem pole about a drug like McKenna or Oxycontin, and they are saying one thing, there are going to be a significant proportion of people, colleagues of ours, that take that as legitimate and factual. I always want to draw attention to the fact that it's not generally your doctor or provider that's working in the clinic that is trying to manipulate you or trying to give you something that may not have the actual data on safety and efficacy. It's usually that they are being unknowingly manipulated. And it's not easy to figure these things out either, because if you're 100% skeptical, you're going to end up not prescribing certain medications or treatments when they are appropriate. But if you're buy into everything that industry wants you to prescribe, then every little problem that any patient has automatically becomes a biological problem where the solution is a biological agent to correct it.
I think you raised a good point, though, about the conspiracy theories, because I try to tell people when I lecture on this, like with McKenna, that you don't have to think of it as a conspiracy theory in the sense that it was everybody sort of in a dark room, the professional medical associations, the drug maker, the FDA. I don't think it has to work that way. But I think what happens is it's not so much a conspiracy theory, it's just pay attention to how the money flows. What happens when you get a successful product, whether it's McKenna or Vioxx or opiates or whatnot, is then it's a successful product. It's selling, it's generating a lot of money. That money can then be used to influence the process for it to continue generating money. And that's what occurs. And then what does the money get used for? It gets used to pay professional medical associations to recommend use of the product. It gets used to pay key opinion leaders. It gets used to pay researchers. It gets used. So then you've got this cash cycle where this drug that doesn't work in McKenna's case, but it's generating revenue, the revenue can then be used to continue that cycle, to keep going. So it really isn't a conspiracy theory as just the way the system ends up working when everybody is trying to maximize profit. That's what it's going to look like. And even a drug that doesn't work can get used for 20 years in that kind of a system.
I just want to draw a little bit more attention to my listeners in terms of your role in getting McKenna taken off of the market. This was something that you started very early advocating for its removal, and you work in your hometown, correct? You're from or around Framingham?
Yeah, I still work at the hospital where I was born.
So your motivation is not to, I mean, let me just ask this question before I continue on. How much money have you made off of all the advocacy to get McKenna taken off of the market in all of the books that you've written and all your appearances? Do you want to tell the listeners how much money I'm paying you to come on to Renegade Psych today?
Yes, zero. No, you're not getting paid. But this points out an important detail, which I'll be quick about, is that the people arguing that for not to use something, there's no money being generated from that because there's no sale of anything. When I'm saying, look, I'm very concerned about McKenna, it's an argument that's not going to lead to the sale of a product. So there's no way to sponsor me. Who would sponsor that message? There's no product that wins that way. That's why the forces on the product side, the forces of industry and the corporations have a leg up in this fight between them and people like me who are concerned because they're generating money from the sale of the product, which they can use to sponsor people. But nobody's going to typically sponsor a message of be careful with McKenna or about the SSRIs in pregnancy.
And you do see that, though. And this is, again, the danger of swinging that pendulum too far, where you distrust all of the official medical dogma, if you will, and you say, I'm going to go with this person who is 100% skeptical of everything. And at the end of their podcast with you, they flash on the screen, take this supplement. It will cure all of your ills, and you will never have to go see the doctor again. So there certainly is the risk of swinging too far in the other direction. There are bad actors out there that are capitalizing on the distrust of the system in a very similar way, trying to convince people to buy something else in response to their distrust of the system.
Sure. I think it's always important to keep on your radar is what's motivating this person that's talking to me. You know, where are they at? And really, at the end of the day, what it comes down to is you want to be talking or getting advice from people that have a heart of a teacher or a kind heart, or that's what they're looking at, is to try to inform you rather than a salesperson. You don't want to be listening to salespeople because they're going to be pitching what they want to sell. You know, you don't get unbiased advice about a car when you go to that car dealer. And whether it's someone that's selling a drug or selling one of these alternative therapies, you have to be very careful about what their real motivations are.
Absolutely. So, Dr. Urato, 2022, my understanding is you presented a detailed analysis to the FDA at a hearing involving the Obstetrics, Reproductive, and Urologic Drugs Advisory Committee, highlighting your concerns about the risks outweighing the benefits with Makena. And then following those efforts, the FDA finally announced the withdrawal of Makena in April of 2023. You and I talked at length about Makena. I would encourage listeners and viewers to follow the YouTube link to listen to our previous conversation. But I really think that your advocacy for doing what's right for your patients and really for all Americans subjected to trials of Makena, it gives you a level of trust with patients and the public at large in an era which Americans are increasingly distrustful of doctors, providers, and the healthcare system. Can you just very briefly summarize the problems with that drug and why you were so adamant for so many years on getting it removed from the market?
Yeah, sure. I think the big thing with Makena was it's a synthetic hormone. It's a synthetic progestin. And we know that when you tinker with hormones during pregnancy, there's a track record there of it causing problems. The one most people know about is DES, diethylstilbestrol, which is another hormone that we gave to pregnant women for decades, and millions were exposed. The idea again was that by giving these hormones during pregnancy, you could improve pregnancy outcomes, but they didn't work. They didn't improve pregnancy outcomes. And in fact, they had worse outcomes. And then there were congenital anomalies associated with that. The ones people usually know about are in females, changes to their reproductive organs. And so there's a bad track record with using hormones in pregnancy. Makena was another effort at this to try to prevent preterm birth in women that had a prior preterm birth. But right off the bat, there were problems with their initial study. It was similar to what you were saying about the psych trials. The drug actually didn't look effective. Makena didn't look effective in the original trial, but it was just that the placebo group had such a high level, a high rate of recurrent preterm birth. Most women, most studies of a prior preterm birth, when you look at recurrent, will have like maybe up to 25%, maybe 30 would be high, lower than that's common. But in the Makena original study, the placebo arm had a rate of recurrent preterm birth of 55%, which is a crazy high number. So Makena at 37% recurrent preterm birth actually didn't really look that good compared to historical levels, but compared to the 55% in that trial. So I knew something was off from the beginning, that it actually didn't appear to be that effective. And then as we used it more observational studies came out suggesting that it wasn't working. And as a hormone, as a progestin hormone, it can cause problems. There were warnings or concerns about blood clots because it's a hormone injection during pregnancy, about depression because it's progestin, it affects on the liver, irritation at the injection site. So women were having trouble with the medication and really no good evidence that it worked. And then the other issue that I always focus on with fetal development is the development of the brain. So the brain has progesterone receptors, and this synthetic progestin, Makena, binds to those receptors in a different way than natural progesterone does. So it likely affects the development of the brain. The development of the fetal brain is this extraordinary thing. You know, when the babies are born, they got these big heads. It's a large brain that's totally wired. To do that wiring requires this really intricate, coordinated dance to put everything together. If you start messing with that with hormone injections or psychiatric medications, it's going to alter that development. There's going to be some effect. And so there are concerns about that. So the long and the short of it was the FDA was waiting to repeat its trial. When it did in 2019, it failed. And then we even more aggressively, I worked on this with Public Citizen, their health research group, helped pull together the petition of the FDA to pull it off the market. And then after that second trial came out, it picked up speed. And then, as you said, finally it was thankfully withdrawn in April of 2023. But I think it's really an important thing worth people looking at or understanding, because it's so indicative of how our current healthcare and medical system work as far as drugs and medications that get used. People are often befuddled. They can't imagine, like, how did we inject pregnant women for 20 years with a drug that didn't work? But there's reasons for that, and those reasons speak to the dysfunction of our system.
I swear, if you were a professional athlete or a musician, you'd get all the accolades in the world for stepping out onto the plank and putting yourself at risk by doing what's right. It's undoubted that you experience backlash because of your advocacy. I don't think people realize how important individuals like you are in turning this dumpster fire of a medical system around. So I got to give you additional kudos and props for that. I'm sure you have your own imperfections and problems, but we have to build up individuals like you as models of how we want our society, especially medically, to evolve. You've heard me talk about the most natural and most effective and safe treatment, I think, in all of psychiatry is lower, more natural doses of lithium. Like everything else, like water, if you take too much, you can have really bad outcomes. But the other factor here, when it comes to depression and the risk of bad outcomes during pregnancy for pregnant female not taking an antidepressant, whatever it is, that doesn't get talked about enough is the protective role of estrogen on mood during the pregnancy. And my very simple psychiatric explanation to my either early pregnant or expecting or trying to get pregnant patients is that throughout pregnancy, your estrogen levels will rise, and that will confer a more natural mood stabilizing effect for you. This doesn't get a lot of discussion. And as I'm saying it, it's generating other questions about estrogen's role in the blood-brain barrier porosity and whether or not it maybe facilitates or blocks the entry of things like SSRIs at higher or lower concentrations. Now I'm all over the place, but respond.
No, it's very interesting. I've asked my colleagues in psychiatry before about this, because with the SSRIs, with a lot of the psychotropic medications, they can be very difficult to get off of for some patients, extraordinarily difficult. And there's a whole movement now on deprescribing and on trying to gradually have dose reductions. I know Mark Horowitz is very active with this and wrote a set of guidelines on this. In pregnancy, we see roughly half of women stop their SSRI when they get pregnant. And it's interesting. I do this on a daily basis. A lot of the women are doing okay. They say they're doing okay. Now, is that different because of the pregnancy? Is that different because of the hormones, because of the estrogen? There certainly can be something at play with that. Yeah. Some women, though, still don't. They don't do well when they come off, and they can be very hard drugs to stop, which is why this is really, with the issue of psych drugs in pregnancy, it's really an issue that needs to be addressed for women of childbearing age. The time to have these conversations is not when the woman comes in at 12 weeks. I often see women around 12 weeks because it's where we do a particular ultrasound, the nuchal translucency, where we measure the baby's neck thickness. That's really not the time, because the babies, a lot of organ formation has already gone on by that time. And also, it can be harder for them to stop for some women. The time to really address this is with women of childbearing age, thinking about these matters, about how you want to approach your mental health. And one thing that's indisputable is that if you take any given population and you say, look, we're going to take an approach to mental health in this population where we emphasize chemicals, where we treat them with chemicals. If you take that approach, which essentially is what we're doing in the United States and around the world now, we say we're going to take this biological approach to mental health, we're going to treat people with chemicals, you're going to end up with a fair bit of chemical exposure during pregnancy, which is going to alter fetal development based on what we talked about at the beginning of this podcast. So that's one method. The other alternative is to not take that chemical approach, which you could, again, make arguments back and forth about, but the benefit or advantage of not emphasizing the chemical approach is you don't get those exposures during fetal development, during pregnancy. So I think that's important. I also just wanted to mention one other issue that you had brought up, the importance of speaking out. I appreciated your kind words about my efforts as an activist. I think it's very important, though, that we support people who are speaking out and who are saying things that may be against the scientific consensus or against conventional wisdom, because many times those voices are correct. I really worry about where freedom of speech is going these days after what we saw through COVID and now even beyond. I think all of us as citizens, as Americans, all of us throughout the world even need to realize and recognize the importance of freedom of speech, letting people have their say. When we try to censor, we can end up censoring away good points, important points. We really saw that during COVID. Jay Bhattacharya, who was making common sense from the get-go with the Great Barrington Declaration and talking about, he's just a good guy trying to look at this as a scientist and say, this is how I think we should be approaching this. And then there was this really active effort to silence his voice. And then we saw more of that throughout the pandemic. And I think it's so essential that we all embrace freedom of speech and making sure we let people have their say. The challenge in doing that, though, is that people have trouble embracing it as a principle because for ideas that they don't like, they want silenced. And that's as important to recognize. Like, you're going to want to support freedom of speech for the ideas you like, but you really need to support it across the board, in particular for the ideas that you don't like, so that everybody has their voice. And that's how humanity can progress, is by hearing voices. And often the progress comes from the voices that are against the conventional wisdom, against the scientific consensus.
Yeah, I mean, we all, for some reason, liked watching Biden and Trump argue with each other about whose golf handicap was lower. But I think as Americans, we would really appreciate having two groups of scientists and researchers and academics having an open debate about some of these issues that we simply kind of weren't allowed to debate about. I don't understand what the harm in having these debates is. I mean, of course, if you are absolutely correct on one side of the argument, but the other side of the argument could convince enough people otherwise, like you could argue that that would be the reason to not have a debate. But we don't see these debates happening anywhere in public forums. And I think that is hugely, hugely problematic.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment. Or, put more simply,
If you need help like this guy, call your own doctor.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.